Ladies and gentlemen, welcome to the Brilliant Mind Studio. Please give a warm welcome to your host from the University of California in San Francisco, Professor Michael Cabana.
Thank you very much. Good evening. My name is Michael Cabana. I'm a professor of Pediatrics, Epidemiology, and Biostatistics at the University of California in San Francisco. And welcome to the Brilliant Minds Studio. We have a different format than most symposia, so we'll have an informal conversation with a few slides, and we'll have some questions afterwards, so please save your questions afterwards. But our topic today will be the importance of microbial exposure for child health during pregnancy and delivery. Can probiotics make a difference? And with me are my colleagues, Flavia and Indrio, Thomas Abrahamsson, and Professor Maria Jenmalm. Welcome.
Thank you. Thank you.
So one of the fun things about coming to a conference is learning about new science, and for me, exciting science occurs when you look at health from a different perspective, or when you put two issues together that you don't normally think of coming together. And I was intrigued by your presentation earlier today, Flavia, when you were talking about gingivitis. So you're looking at maternal gingivitis and preterm birth. But to me, Flavia, maternal gingivitis is a local oral health issue and not a systemic issue. But for those of us who weren't here earlier today, maybe you could give us some background on that work.
Yeah. Oh, wait, I use this. Okay, thank you, Michael. Thank you, everybody, to stay still here. But yes, sure, it was thinking to be just a local disease and nothing to deal with, no problem, until since 5 to 6 years ago, periodontitis and gingivitis was related to a lot of systemic disease like non-alcoholic fatty liver disease and inflammatory bowel disease and preterm delivery, cardiovascular disease and Alzheimer, respiratory disease. And of course, we focus more on the systemic effect of a pregnant woman, because a pregnant woman, if carry an inflammation into the mouth or a, let's say, local disease or something that is just thought to be without side effects of, let's say, far away side effects, it's something that could be affect the pregnancy, and what is much important for our being a pediatrician, that affect the health of the baby. So this is something related to the immunity of oral cavity. I already talked about this morning, but just to recap, that is a difference in between gut-associated lymphoid tissue and oral immunity, or the immunity of the oral mucosa. There are some anatomically different, but as you can see here in this slide that I already showed this morning, there is a change in the epithelium layer and in the submucosa. Epithelial layer of the oral cavity is multi-layer. And so the question could be, what's happened to the intraepithelial lymphocytes? Because generally they are expected to be the first soldier with the environment. Intraepithelial lymphocytes in the multi-layer epithelium of the oral cavity are present. Even they don't are very in contact with the environment, they are very much in contact with the mucosa. And the other difference is that in the mouth, there is no submucosa. So the question could be, where are the associated lymphoid tissue, where are the Bayer patches? The Bayer patches are represented by the Valdeyer ring, tonsilla adenoides, and even in the oral mucosa, it's more represented the capillary vessel. And the dendritic cells and the lymphocytes that are located in the oral mucosas are much more specialized, because the dendritic cells that are presented in the oral mucosa have the capacity to promote the inflammasome activity.
And that leads to this is my question. So after your presentation this morning, is the gingivitis directly related to preterm birth, or is it an indirect effect? Or are they two things that may be associated and a marker for something else?
Yeah, as I say this morning, we can have two different ways that inflammation of the oral mouth can reach the, let's say, the womb. Of course, this slide I show you again this morning, and this is present how there is the colonization of this hypothesis, in utero colonization hypothesis. I show you this not to show the vaginal transmission from the mother to the amniotic fluid, but just to show how the fetus could swallow amniotic fluid, as Joseph Nuss say, 150 ml per day. That is a huge amount. So if we have a dysbiosis, then we have a dysbiotic fetal intestine. And again, as I say this morning, the start of preterm delivery come from the intestine of the baby. And so this could absolutely be related. There are a lot of studies that are putting this in combination, gingivitis and preterm delivery.
So the title of our session is, Can Probiotic Interventions Make a Difference? So what work has been done to lead to either treat preterm birth or treat gingivitis?
Yes. As again, I showed this morning, there are a lot of studies that have been done related to the treatment or prevention, but more the treatment of gingivitis during pregnancy. And because, as I say, the rate of the incidence of gingivitis in the pregnant woman is just doubled over compared to the normal population. I talk about 40% in adult incidence and 80% in pregnant women. So I showed this morning a lot of strain, but the most studied strain is this one, where the last you can see here, where has been shown how this strain of probiotic that are a combination of two strains, I will show you, are two strains of Lactobacillus reuteri, one DSM 17938 combined with Reuteri ATCP TA 4289 that have two different effects on the mucosa. Of course, Reuteri, it's the main producer of Reuteran, and the other strain is reducing the inflammation by blocking the TNF and alpha. And in this study, as a particular, it was how the pregnant woman that took this probiotic that were supplemented with this combined strain had a reducing not only in the rate or in the level of gingivitis and periodontitis, but also was evaluated the level of TNF-alpha. So
if there's a direct link, I noticed that the endpoint here is gingivitis. I guess the real endpoint that you're driving towards, if this paradigm is correct, is preterm birth. So that seems like that's the next step, and that's the next goal for your next study.
Absolutely. And so far, no study have been published between these two links. Because, of course, as I say again, this morning, a lot of study in gingivitis and periodontitis during pregnancy. A lot of study in probiotic in general during pregnancy. But what about study that treat and cure gingivitis and prevent preterm delivery or other outcome in the fetus or in the newborn? So far, no study. So we designed this multicentric double-blind randomized control study with a duration of 18 months. It's in collaboration with Pedro Gutierrez Castrillon in Mexico, so it will be done in Italy and in Mexico. And we will diagnose all the pregnant women and follow them affecting the periodontal disease. We will cure, we'll supplement them with probiotic or with placebo, and then we will, we will look to several and different outcomes, not only of the preterm delivery, but also later in life for the newborn.
And this is 300 pregnancies?
We are thinking to include 300 because the statistic, you are an epidemiologist, so you will know much better than I do that the number needs to be high to have a significativity of the study. Yes, sure. That we are thinking to include 300 women.
Well, my last question is, will the study be done in time for the next PPP meeting in Chile?
Hopefully, November 19, maybe yes. We'll see what our ethical strong and committee will talk about. Yeah, sure.
Okay. Well, you heard it here first. So the preview for Chile. So this is the gingivitis represents maybe some of the bad effects or the detrimental effects of microbial exposure, but Tomas, you've worked on the positive effects of maternal antigen exposure during pregnancy. So there's a detrimental side and potentially a positive side. Can you tell us about some of the work that you've looked at?
Yeah, so I started to realize the importance the first time when the first allergy prevention trials with probiotics arrived 10, 15 years ago now. And it seemed, to our surprise, it seemed that the treatment of the mother and the child, but the mother during pregnancy was mandatory for the clinical or the effect on infant eczema. And now it has been plenty of randomized controlled trials, as you all know. And this is a meta-analysis from Pandurum from 2015, not 2018. But what he did, what they did, was that they stratified depending on the timing of the treatment to mother or the child. So if the mother, oops, that was the wrong. So yeah, there we are. So if the mother was treated or supplemented during pregnancy, and the child got it also afterwards, the overall effect was 0.61 as a risk factor or risk ratio, 40% reduction. I will not talk about specific strains, but the overall effect was that. But if you only treated the child, the studies that only treated the child after the birth, you didn't see any effect, and that means that it seems that the treatment during pregnancy is crucial for the effect on the infants.
So this is a series of studies. Are there any other, besides clinical trials, any other evidence that points to this effect of prenatal exposure?
Well, yeah, so at the same time, 10, 15 years ago, there were these farm trials. You have probably heard about them, all of you. Children growing up in farms had a reduced risk of having atopy or allergy. But what Ege and colleagues showed was that it was actually only true if the mother worked in the stable and was exposed to the cattle and had the microbial exposure. As you can see here, the odds ratio was 0.58 if the mother worked during pregnancy in the stable, while if she didn't, the odds ratio was only 0.96 and not significant.
So when the odds ratio is less than 1, it connotes a protective effect.
Yeah, yeah.
I guess the 0.96 was too close to 1 to be statistically significant.
That's
so with observational studies, there's always the risk of confounding. In the Cabana family, we're all very allergic, so we would make terrible farmers. So you would never see allergic cabanas working on a farm.
But your mother maybe didn't work in the stable either.
She's a pediatrician. So that's why we became
there you are. Yeah.
So I guess, are there any experimental studies?
Yeah. So there are plenty, but I chose this one, or those two actually, by Conrad and Brandt, because they actually isolated the bacteria from those farms trials that was significantly associated to a lower risk of having atopy. This Acinetobacter evolfi. And they use an experimental asthma model in rats. You sensitize the newborn rats, and they got asthma-like symptoms. But if you treated the mothers during their pregnancy, the asthma-like symptoms was reduced, or were reduced. And they actually also cultivate, or they checked for cultivation or for colonization of this particular bacteria in the offsprings, but they were negative. So it wasn't because it was transmitted from the mother to the child. So then they focus on the epigenetic effect, and they look at histone 4 acetylation. And it's hard to actually paint like this, sitting here. Yeah, so... Yeah, I know. You can look here instead, yeah. So what they did, they isolated CD4 positive immune cells from spleen in the offsprings, and they look at this acetylation. And they saw that the acetylation was lower in the interferon gamma promoter gene and higher in the IL-4 promoter gene. And that was reflected with a lower Th2 cytokine profile and a higher interferon gamma cytokine profile in the offsprings. So, which means that the treatment of the mother affects the immune system in the child.
This is similar to some of the information that Dr. New presented earlier this morning.
Yeah.
So you have maternal exposure, and it's affecting the child. What's the mechanism? And then I assume the timing is during pregnancy.
Yeah,
but
yeah.
In terms of the mechanism.
So that's obviously the hard question, since where's the link? And you have seen this this study several times already this day, from Augard and colleagues, showing this unique microbiome in the placenta. And the interesting thing is that this microbiome differ quite much from the vaginal flora. It's not here, but they actually show that too also. And it was diverse. And it was resembling also the oral cavity flora, which is interesting in context of what Flavia told us recently. So, and they argue that the bacteria probably was transported to this site via the bloodstream, which is really interesting. And so you can speculate, of course, how these bacteria get there and expose the infant. And I make a cartoon here. So there are studies showing that, and I think Nu also mentioned that dendritic cells are sampling bacteria from the gut lumen in the small intestine. So that is, you have proof for that. So the cells sampling that. There are studies in animal models that showing that dendritic cells contains bacteria in the bloodstream. And now we have these studies showing that there are bacteria also in the placenta. So this could be a possible link from treatment of probiotics, for example, or other bacteria, how it reach the placenta.
So in terms of, do you think the womb is sterile? Are you suggesting translocation?
So there has been discussion about sterility or sterile. I mean, all these studies, and that is important to remember, almost all these studies has used DNA-based methods. So we don't have proof that the bacteria is actually alive. It could be just bacterial DNA or antigen that is there. But the question is if that matters. I mean, if there are bacteria that affect the immune cells or the epithelial cells by their antigens, maybe that is as good as they were alive.
Okay. Well, that's a very interesting idea. I know for me, it's changed the way I've thought about the womb and thinking about that different paradigm. But the prenatal exposure is very important, but also another common theme through the meeting has been the effect of the transition from fetus to infant and the mode of delivery. So whether it's C-section or vaginal delivery. And Professor Jenmalm, you've done some work in that area. And can you explain a little bit more about that transition and the importance of that transition?
Yes, thank you. So I think that this idea of transfer of microbes from mother to baby is a really important concept, and here I would also like to point out that the mother is not only transferring microbes to the baby, but also actually passive immunity along with these microbes. So during pregnancy, so I point here now, IgG antibodies are transferred through the placenta, and some of these will be directed towards those microbes, and also later during breastfeeding, IgA antibodies directed to the microbes can be transferred. So the mother transfer both immune components and microbial components, and I think this transfer is really important, and I think that it is very interesting to think of this concept that exposure to bacterial products can be important for immune imprinting of the fetal immune system, and kind of a way to prepare the baby for what comes after. And then, of course, I think that delivery is a very important time point to then give the first large inoculum of microbes, and that both bacteria from the mother's vaginal flora, but actually also stool bacteria, I'm very convinced of that, are transferred as well to the child, and that you can see this as a continuum with transfer both before, during, and after birth. And I think it's interesting to hypothesize that this is important for child health and immune maturation.
The method of transmission or the method of delivery makes a difference. The obstetricians at the the obstetricians at the University of California are very proud that their cesarean section rate is so low. It's only 22 or 23%, which is low for our part of the country. But
so we have
7.
Oh, even better.
Yeah. They worked really hard in Linköping with this.
That's very impressive. 7%.
In Linköping.
Yeah.
Very good. Well, and because there's
10,000 people, habitants.
No, much more.
well, we're 600,000 in San Francisco, but
Yeah.
because of that rate, it makes it sound well. They're proud of the rate because of the long-term potential detrimental effects of C-section, and I was hoping you could talk about that also.
Yes. Yes, so as already discussed during this meeting, there have been done association studies looking at children that were born through cesarean section or vaginal delivery and finding an increased risk for various allergic diseases. So this is a meta-analysis showing increased risk of food allergy, allergic rhinitis, asthma, and also hospitalization due to asthma in children delivered by cesarean section. And there was also other meta-analysis done for type 1 diabetes, and it's also been speculated if it can influence also other immune-mediated diseases. And of course, these are association studies, and there can be confounding factors and so on, but at least it's been repeated in many different studies with similar findings.
When we did the TIP study at the University of California looking at probiotic supplementation, we also thought that kids who were born by C-section might benefit from probiotic interventions, but there's other evidence as well, isn't there, of probiotic interventions for C-section in preventing this?
Yes. So regarding allergy prevention studies and the effect in cesarean delivered children, it's important to note that there are no studies so far that have been done that have been originally designed to address this hypothesis.
Ours was an ad hoc.
No, yeah, exactly. Yeah. So this was the largest study performed so far in Finland, where they had almost 900 infants included. So here they show a reduced eczema at 2 years of age, but then the effect was lost at 5 years of age on allergic disease, so it was a more short-term effect. But then they did such a post-hoc analysis to see if maybe cesarean section delivered children would benefit more. So they had a reasonable number of children in these groups to do this comparison. And then they could observe that the probiotic had a more long-lasting effect in these potentially more vulnerable children. So I think this is a very interesting finding, although it is important, of course, to perform studies that are originally designed to look at this question.
Well, it sounds like it would be hard to do that study in Linköping if your
cesarean
section rate's only 9%, so, or 7%. Very good. But the one of the other outcomes besides eczema, which would take 1 or 2 years to establish, would be how the microbiota changes in the first year or two of life, and that's an outcome that's been looked at as well too.
Yes. So the effect on mode of delivery on gut microbiota development has been done now in several studies, and this we were one of the first to use next generation sequencing and follow the children at various time points. So here to the left we have children delivered vaginally, and here we have cesarean section delivered children, and you can see by eye here that the green phylum of bacteria have a much lower abundance in the cesarean section delivered children. And I would like to point out that there are now at least 12 different studies from various independent groups that have shown a low Bacteroides colonization in cesarean section delivered children, including this study that was presented by Professor Zawieska this morning that states no effect on mode of delivery. But if you want to look, they have hidden in supplementary figure number 12 the Bacteroides colonization data. And I done a Fisher's exact t-test calculation, and it's a very significant difference also in this study, but they chose not to present these findings. But I would like to state that this Bacteroides reduced colonization rate is very clear in all these studies. And also this bacterium is a more prominent member of the gut microbiota and not the vaginal microbiota. And we and others have also shown that the vaginally delivered children seem to share a lot of the gut microbes with their mother's gut microbes, but not the cesarean section delivered children.
Yeah, and go ahead.
Yeah.
Well, as I understood it, Bacteroides doesn't survive outside the body even, so it need to be transferred at the delivery period. Yeah.
This would be another opportunity for probiotic intervention as well too, to see if it affects this as well, and what work has been done in this area.
So I think more studies should be done. We found one study from Greece looking at the effect in formula-fed children that were delivered by cesarean section if probiotic could affect the microbiota. And here they got the probiotic for the first 6 months of life, and they could see at 2 weeks of age that the children that got the probiotics and were delivered by cesarean section, that they had a gut microbiota more similar to the vaginal delivered infants, but the effect disappeared at 4 months of age. And also in these children that were not breastfed, it also seemed that at 2 weeks of age, the probiotic increased the relative abundance of bifidobacteria in this group.
But thanks for summarizing that work. We've covered several different topics, but there seems to be a theme: the effect of maternal gingivitis or oral health issues, the fact that prenatal exposure makes a difference, and also the effect of delivery as well. I guess comments in terms of what the next steps are. I guess a common sentiment is more research is needed, and before we commit to any specific interventions.
Yeah, and I would like to comment also here when talking about the importance of the prenatal period in this allergy prevention trial. In most of these trials, probiotics were given from gestational week 36, just to colonize the mother and for the bacteria to be transferred to the baby. But if this prenatal exposure is so important, one might think of prolonging this treatment. So we have a study ongoing now where we give probiotics from gestational week 20 to see if that could have a more preventive effect. Yeah.
Okay, thanks.
Just a comment, about future research. The problem is that, as you well understand, the pregnant woman, need to be supplemented by gynecologists. And still gynecologists, as our colleague this morning say, doesn't have this mindset of supplemented of probiotics. So they are just like pediatricians were 10 years ago. And the dentists, the study industries are very scattered, and the meta-analysis are very difficult to do it because quality of the study are very low. So there needs to be a work of education, let's say, education scientifically speaking. And there's a lot of street to do, road to do, but it's promising. My point of view is that's absolutely promising.
I'd have to agree. I think a lot of the advances that occur in pediatrics occurs when pediatricians and neonatologists collaborate with folks from other fields as well, whether it's obstetrics or microbiology or internal medicine or surgery as well too. So many more advances. We've purposely made our conversation short so that we would have time for questions. So I was just going to build on that. So if the prenatal exposure is really important, you're saying you're starting at 20 weeks gestation. Why not sooner?
Yes, so this was basically that we were thinking if for safety reasons, we were thinking that, if problems occurred, it's more likely that they will not occur after gestational week 20. So, of course, there are no studies suggesting adverse effects in pregnant women, but that's how we reasoned when we...
So you were worried about... Yeah, sorry. So potential complications with the mother or the child or both, but...
Yeah, that it could be problematic for our study if there were like miscarriages and things like that, even though they would be related, we would think to the... and then one could theorize also from an immunological perspective that at gestational week 20 there are circulating lymphocytes in the fetus and immune cells there that we think would be able to influence as well.
I have a question for Flavia and one for Thomas. Flavia, regarding the intervention during the pregnancy for women who have periodontitis, gingivitis, etc., it is the same to begin with the treatment or as adjuvant for probiotics early on the first phases of the pregnancy or during the second trimester, etc. What are the adjusted evidence trying to do a meta-regression consider when you decide to use probiotics as a treatment or as adjuvant for periodontitis? This is the question for you. And for Thomas, almost the same. When we decide to reduce the risk for some atopic dermatitis like eczema, it is the same to give the probiotic during the pregnancy early, during the second trimester, or there are no differences between them?
Okay, thank you, Pedro, for this question. And of course, everybody of you knows that 14 weeks of gestation, the development is already set. What is not set is the, let's say, epigenetic changes. So as we have in our secondary outcome, the 6 months of health of the baby, and we heard today that how so important the development later in life, not only in the first 2 years of life, but in adult life. As soon as we gave supplementation, as soon as we influence the development of this changing in the fetus, even though we are beyond 14 weeks, this doesn't matter because 14 weeks of gestation, is just anatomically set up of development, not functional. So definitely as early we start, as much we have the effect.
Yeah, Thomas talked some moments ago about what are the potential mechanisms when you use one probiotic into the mouth and then they reach the placenta. And they talk about the digestive interaction with some dendritic cells, etc. But other mechanisms is directly to the blood. When you give a probiotic that persists into the mouth and then they enter into those lesions who have the women who have periodontitis, they enter directly to the blood and then they go to the placenta and establish some different relationship with some fetal cells who are related with the immune system. So it is not only to talk about the first trimester or the second, but also talking about epigenetic secondary to those persistence of good bacteria into the placenta during the whole period of the pregnancy, talking about epigenetic. It is on that way or not?
Was it a question to Flavia?
To Flavia.
Yeah. Thank you, Pedro. Thank you so much. I was just missing this. And of course, it's not a matter only of colonization. As we don't know the pathological or the mechanism of the bacteria, of the probiotic, maybe it's a matter of producing product of this bacteria. So you can imagine, I showed this morning the capillary net, and how this capillary net is in biochemical contact with the bloodstream. So you figure out how can be dangerous, how can be detrimental if you just keep producing like inflammatory cytokine that go directly to the placenta and not only provoking the preterm delivery, but also provoking a different epigenetics development. So again, I would be much more careful to have a reduction in production of inflammatory cytokine. As far we don't know, again, the mechanism of probiotics. So I would rely on cytokine or fermentation product from the bacteria.
Okay, so I think a question was about timing, and I think the timing is always it is really important, and I think the reason we gave the mother the probiotics from gestation week 36, and you know it could the gestation, normal gestation is between 37 and 40 something. So I mean a lot of the women just got it 1 week before the actual delivery in most studies. And the reason we gave it was, as Maria said, was that we wanted to have a colonization as soon as possible to the infant. And still it obviously could be that this is important, and it's not this route via the placenta. But I mean, I think if we think that we should treat the mother during pregnancy, and we think the microbial exposure is important, then we should prolong the period and have it a longer time. And the limitation in intervention trials is what Maria said, that you don't want to treat the mother in gestation week 13 maybe, because then we don't know about malformation and other problems, and it could have quite big problems if something happens, and was it the treatment or was it not? So that's why. But I mean, the interesting thing is that it seems, although you know that it's strain specific, so that could explain difference between different trials, but it seems that you have to treat the mother during pregnancy, but also the child afterwards, or at least the mother when she is lactating. So it seems that you have to. It seems that the mother has to be exposed, but also the infant of the same strain. So I think that is really interesting, but hard to understand. But maybe it is that the mother, let's say this is true, as I told you. So maybe the mother exposed the child for this specific bacteria, this probiotic bacteria, and then when the child got it afterwards, it already recognized it. And then it could be a tolerogenic effect or etc. in the gut. So yeah, speculation, but it seems that both treating the mother and the child is important.
Stanley Wellington, New Zealand. We published, Wickens, first author, the previous study where we compared 2 probiotics with placebo and demonstrated a 50% reduction in eczema. I can't give you the results of the 10-year follow-up, but they're very exciting and they're coming out very soon. But I can give you the results because they are published over the second study we did, where we decided to only treat the mother. And Maria, we decided to go from 16 weeks or less. So they were all before 16 weeks gestation. And the safety data is all out there, and it's very safe, at least HN001, which is our version of Lactobacillus rhamnosus. The sad truth, however, is that even though the mother took the medication, the probiotic throughout pregnancy, and as long as she was breastfeeding, there was no effect on the babies at 1 year of age. So that's published CEA about a month ago.
Did you use the same strain that was
exactly the same strain as worked last time. And we also looked for the strain in the breast milk, and in the, I think, 13 or 14 women we looked for it in, because it's very expensive, we couldn't find it in any of them. So we don't think it's probably coming through in the breast milk either. And I think the conclusion that we've reached is that you have to give it to the mother and you have to give it to the baby, at least for eczema.
As I also think.
And I would just like to clarify, we didn't think that we would get an increased rate on serious adverse events in our treatment arm, but we just thought if, because you do interim analysis and so on, and if something happened and it was in the active arm, how should you do? So it was more like that, yeah.
I have a question for Thomas Abrahamsson. The idea is that if you have given to the mother this probiotic, and then is there any evidence that giving to the infant afterwards would increase the likelihood of decreasing the rate of allergy? And if so, for how long would you be treating the infant after?
So there are evidence that if you treat the mother and treat the child also, and you do meta-analysis, you see you can see a difference. But the problem is that a lot of negative studies. So here the specificity of the strains seems to be really crucial. And we have the same problem as you heard about the neck meta-analysis. You kind of comparing apples and pears. So it's hard to recommend a specific strain because very few studies that have been replicated. So it's actually some studies with LGG that has been replicated, but they were negative. Okay. So it is still, it seems that it could have an effect, and the WAO, they actually recommend prevention, although it's low evidence, they say. But I think you should go for a strain that has been proven to have an effect, and the one that they use in New Zealand is obviously the one that has been maybe most effective.
Yeah, but for how long then you would recommend the treatment?
For how long? Yeah, that's also in the studies it's different. So in our study we had 12 months, but many studies had 6 months. And I think the study from New Zealand, you had 24 months, and that is the study actually that showed really strong effects, also more long term. But it's the same thing again, it's different probiotic strains, different doses, different timing. So more studies are needed here also.
Yeah. And then I have a question for Flavia, because you told us that if you have periodontitis, you increase the risk for the infant. But do you think that the probiotics should be also used in oral cavity of healthy women?
This is a good question. Maybe if these healthy women are longing or aiming to get pregnant, maybe could be even better, because the new the new hazard now is this sterile woman or couple, and maybe just, let's say, to create a healthy environment could be another option. Sure.
So I must say these New Zealand trials are really interesting in a research specific, since you have used the same strain and you did it differently, and only one of them, the way you did it, have an effect. So that is kind of quite good proof, actually. Yeah.
Hello, I'm Ana Paula from Brazil. It's a practical question. If I have two demands, I would try to prevent periodontitis, for an example, and also a family of risk of atopic dermatitis. What should I do? Should I choose just one, or I should combine the best studies for the two reasons to prevent?
This is a very intriguing question. We were talking always about this strain specificity. So, and also Anya or Michael are identified also for prevention, and Thomas, prevention of allergy as strain specificity. And also for gingivitis or periodontitis have to be like this. Not yet identified what is the ideal strain, at least for periodontitis and gingivitis, neither for the one to prevent preterm delivery, but you should choose what is the worst clinical condition, maybe. I could not answer properly at this question so far. Maybe?
Well, I agree. What is the worst condition you could get, and maybe also what is the risk for you? I mean, it could be that you have a high risk of allergy. Maybe you should choose the one that is good for that one.